So let's talk about some of the challenges with the sepsis bundles. What you see is, and the first point is the hour one controversy. These recommendations that are in the management, and it's published in the documentation here, you'll see that the grade of recommendation and level of evidence is either a weak recommendation or a low to moderate quality of evidence to recommend measuring lactate, blood cultures, administering antibiotics, fluid of 30 mils per kilogram, and vasopressors. The lactate issue, the table on the right looks at serum lactate levels based on whether the patient has SIRS, sepsis, severe sepsis, or septic shock, and basically there's really no difference in the sepsis in the lactate levels in these patients. There was a question of what are the clinical implications of the changing definition of sepsis. The clinical implications are huge because, as you see, the incidence of sepsis varies based on which definition you use, and using SIRS criteria to screen patients, when we get to that, is completely different than using other techniques to screen patients. So there's a difference in identifying and the incidence of sepsis, of identifying these patients. There's a challenge with the sepsis bundles of definition of T0. I want to address this in the bottom part of this slide. Since the bundle elements are timed, so you have to complete treatment measures within a specified period of time. Whether you believe in the 3 and 6 hour one bundle, that it's timed. When does the time start? The time starts at T0. That's when your clock starts. However, the question is, when does T0 really occur? And the most recent recommendation from the Surviving Sepsis campaign as of May 2018 is time zero is defined. There are actually two different definitions for T0. And it depends on where the patient is located. In the ED, T0 is time of triage, which means if I triage you at noon, but you do not declare yourself, because sepsis can be a slow, insidious process, but you do not declare yourself of having sepsis until 2 o'clock, T0 is noon. And it's now 2 o'clock, and I just identified it. I already missed my hour one bundle. And if you use the 3 hour bundle, you're already 2/3 of the way through your 3 hour bundle. So in the ED patients, T0 is time of triage. In admitted patients on the floor in the ICU, if presenting from another setting, care setting, which means floor or ICU, T0 is from the earliest chart annotation consistent with all elements of sepsis. So in floor and sepsis patients, it's the time the data in the chart documents sepsis. In other words, if the vital signs in the laboratories indicate sepsis in the chart, and you do and let's say that happens at 1 p.m., but you do not clinically recognize it until 4 p.m., 4 p.m. is not T0. T0 was 1 p.m. And again, you've eaten into your 3 and 6 hour bundles. So how is neonatal sepsis different from adult sepsis? Actually, there was the first pediatric children's sepsis guidelines was published. I believe it was in 2016, 2018. There was published guidelines on children for sepsis. It follows very similarly to the adult guidelines, and that was published in Critical Care Medicine, and that is available. You should be able to find that. So here's another challenge with T0. This was a study that looked at 80 definite sepsis cases. And it reviewed the cases to see how much inter-rater reliability there was in determining T0. And it looked at one hospital case manager, hospital abstractor, which submits the claims, and 2 clinicians, physicians, infectious disease folks, pharmacists, et cetera. And basically what they found in the top bar here, all 3 evaluators agreed with T0 within 1 minute of each other only 36% of the time. So in only a little bit of a third of the time, more than a third of the time, did people agree with T0 within 1 minute of each other. So there's a lot of disagreement, and the inter-rater reliability was a kappa score of 0.39, which indicates poor inter-relator reliability of being able to identify T0. Now, what's another challenge with the sepsis bundles? Let's talk about antibiotic administration. Antibiotic administration, obviously, is you're supposed to get cultures and start antibiotics within 1 hour of the identification of sepsis. So the current clinical definition of sepsis, based on sepsis 3, is suspected or documented infection, presence of organ dysfunction, and signs of a dysregulated host immune response. So presence of infection, again, however, 40% of patients suspected of infection are later found to have low likelihood of infection. 30 to 40% of patients never grow a positive culture. So although you're getting cultures, 30, 40% will never get a positive culture. The balance we have, the risk we run with antibiotics, especially with the hour 1 bundles, is, do I treat this patient just in case they have sepsis, or do I hold off? If you treat just in case, the problem you run is, and we've seen this happen with the hour 1 bundle recommendations, is increased antibiotic exposure, which increases resistance. And now we're getting resistant organisms to sepsis, or sepsis with resistant organisms. You run the risk of organ injury with some of these antibiotics, and you run the risk of Clostridia difficile infections, which we're seeing. So if I treat just in case, and 40% of the time they don't have sepsis, 20 to 40%, depending on who you read, they don't have sepsis, I'm exposing the patient needlessly to antibiotics, and I'm exposing culture, the population, needlessly to potential resistant organisms. However, if I don't treat, then I run the risk of increased morbidity and mortality. And as the slide says, item D, it's commonly quoted that every hour delay of starting antibiotics increases the risk of death in sepsis by 7.6%. Well, this is true, and a lot of people say this. However, this data has only been shown in septic shock patients, not in patients with sepsis without septic shock. And there have been a couple of studies in these graphs that you look at. The first on the left basically looked at 35,000 sepsis patients and the time of antibiotic administration, and compared time to hour 1, which is the first data point. But if you look at the data points in antibiotics at hours 2 to 5, there's no difference in mortality between hours 2 to 5 in giving antibiotics. So do you really need to give antibiotics in general sepsis patients within the first hour? You probably should try to start it, but if you start it between the first 2 to 5 hours, there's probably no difference in mortality. The study on the right was a recently published paper. They looked at 24,000 patients. And most people say, from what is the delay for me getting antibiotics into my patient? And it typically is the total time to get the needle in the arm. And what this study said is there's actually 2 time points you need to look at. The first time point is from ED triage to ordering the antibiotic. That's the first time point. And then the second time point is from the time that I order the antibiotic to the time it gets into the arm. So as you're building a sepsis program, you should consider these two elements, because based on this table, the purple bar on the far right of each of these demonstrates that both with all septic patients as well as septic shock patients, the average time from time of order to get the needle in the arm was only 30 minutes. The biggest delay, averaging somewhere between 1.7 to 2.7 hours, was from ED triage to ordering antibiotics. That's the big delay. So if you want to improve time of antibiotic administration, it's time to recognition from ED triage to ordering the antibiotic. That's the area that we need to improve upon.